Hello, and welcome to Quality Care Rounds at Partners Community Health. My name is Rahul, and I'm the attending nurse practitioner at Wellbrook Place, supporting both the East and the West Towers. I will be facilitating these sessions, which are scheduled for the third Thursday of every month. Staff can attend either live in person here in the Seniors Hub or virtually online through Teams. These sessions will also be recorded and made available for staff to access on their own time. Now, the goal of Quality Care Rounds is twofold. First, it is a monthly education series that builds knowledge capacity for staff on relevant health topics to improve the level of care for our residents. And second, it creates a platform to engage in meaningful conversations about these topics and to clarify any concerns about them. So for our inaugural topic today, we will discuss communicating with healthcare providers. So there are four main objectives to support today's learning. First, we will introduce the various healthcare providers supporting the team, as many of you have likely already worked with them in different capacities. Second, we will learn to identify the clinical urgency for residential concerns in the units to better navigate the communication process. This will compare situations that should be deemed urgent versus non-urgent. Third, we will try to summarize the communication algorithm for staff to safely escalate urgent situations. And fourth, we will demonstrate a standardized approach to effectively communicate urgent health concerns with the various providers by using the SBAR tool. So who are the main healthcare providers on the team? First, there is the physician, which is the most responsible provider, or MRP, for the resident. They are typically assigned to a single RHA, but will have residents and other units under their care as well. They facilitate weekly on-site rounds, but the day may be different for every MRP. They are responsible for admitting new residents to their RHA, which includes admission orders and a comprehensive medication reconciliation. Ultimately, the MRP manages the chronic health conditions for the resident. Now, chronic refers to conditions that develop slowly and can worsen over time. They are not necessarily urgent concerns on a day-to-day basis, but they can be. They require long-term disease management, and some examples include diabetes, hypertension, COPD, congestive heart failure, and dementia, just to name a few. Some common concerns related to these conditions may include poorly controlled blood sugars for diabetics or a reassessment of blood pressure medications for hypertensive residents. Ultimately, staff should be contacting the MRP for these types of concerns related to chronic disease management. Next, Wellbrook has an attending nurse practitioner, which is me, and I'm on site Monday to Friday, and I'm typically available to see residents between 10 a.m. and 4 p.m. This changes periodically as per operational needs. The main reason to contact me would be to assess and provide recommendations for daily acute health concerns that are episodic in nature. Acute refers to a sudden change in a resident's health or development of new symptoms over a short period of time, such as sudden shortness of breath in an otherwise stable resident. Ultimately, all of these episodes are time sensitive and require immediate intervention, as a delay would compromise the health and safety of the resident. There is an NP stat table placard in every RHA with examples of acute concerns, some of which may include a new fever, an infected or worsening wound, or bleeding noted in the catheter drainage bag. Please see this placard for additional reasons to call the NP. I also provide education and support for staff through informal team huddles on the units and formally with these quality care rounds. We also have the NP Stat program from Trillium that supports Wellbrook. They do on-site visits, primarily done by Cara and NP, but their schedule varies. They provide on-call services as well. Their mandate is threefold: to prevent unnecessary hospital transfers, to support safe repatriation of residents back to Wellbrook that were transferred to the hospital, and to provide acute episodic care. As you can see, there's overlap in the clinical mandate between the attending NP and the NP stat, as they both address acute health concerns, but that provides additional support for staff. There are also on-call services by telephone for a physician from 5 p.m. in the evening till 7 a.m. in the morning. Each MRP is responsible for their own residents during the day and should be contacted for any chronic health concerns, not the on-call. The NP stat also has similar evening and weekend support with their hours listed on the slide for acute episodic care. The contact numbers for all providers are available in every RHA. Finally, there are virtual internal medicine consults available for hospitalist support by Trillium as well, with a 3-hour turnaround on the weekdays. So now that we have introduced the different healthcare providers, how do staff determine if a clinical situation is urgent or non-urgent? Urgent concerns are those that are time-sensitive and require priority assessment over other concerns, as delaying could escalate the health and safety risks to the resident. Therefore, these concerns require immediate intervention or recommendations that require a same-day visit. For urgent concerns, call the healthcare provider. An example of an urgent concern is a stage 3 pressure injury on the coccyx that is worsening and now has a malodorous discharge with the resident endorsing more pain. This requires same-day assessment and therefore is considered urgent, so call the healthcare provider. Some examples of urgent concerns include acute episodic care such as new pain, signs of infection, sudden changes to cognition, or changes in breathing. Another example that is urgent is a previously stable resident that is rapidly declining, such as abnormal vital signs beyond their baseline, a low level of consciousness, or even hypoglycemia. Another type of urgent concern are time-sensitive matters such as a resident who previously fell and has a potential injury, suspected abuse, or extreme changes in eating patterns. An urgent concern may also be a complex wound that is worsening, possibly infected, and is beyond the scope of the wound care policy. Some other urgent examples include abnormal lab results related to a safety concern, such as a positive culture that requires treatment adjustment, or medication reconciliation for newly admitted residents. Ultimately, all of these urgent examples necessitate more immediate assessment, and therefore, staff should call the healthcare provider. NP for acute cases, the MRP for chronic. On the other hand, non-urgent situations refer to health concerns that are not time-sensitive, as a same-day visit is not necessary and likely can wait to be assessed during the physician weekly rounds. In these situations, the health and safety risks to the resident do not change if assessment happens, for example, 2 days later. For these non-urgent health concerns, flag them in the MD-NP communication binder. An example is a resident that develops an area of redness on the coccyx that is a stage 1 pressure injury. In this non-urgent case, follow the wound care policy for management and write in the communication binder for assessment during weekly rounds. This slide shares some additional examples of non-urgent health concerns, such as reviewing normal lab investigation results, abnormal labs that are not related to an urgent concern, signing forms not related to an urgent concern, and chronic disease management that requires reassessment, such as uncontrolled blood sugars or blood pressure, or worsening chronic pain. Again, these types of non-urgent concerns should be written in the MD-NP communication binder for weekly rounds. Next, let's talk about how to safely escalate a situation. The previous slides shared examples of urgent and non-urgent cases. Therefore, to identify the path for elevating a health concern, staff must first determine the urgency of the situation. This is done by assessing the resident with a proper health history, conducting a focused physical exam including taking vitals, and reviewing any appropriate lab or imaging results. Staff should then implement appropriate interventions within their scope of practice. So for example, simple stage 1 and 2 pressure injuries should be managed according to the PCH wound care policy. Now, if the situation is deemed to be urgent or beyond your scope, you should call the appropriate healthcare provider, which again depends on the type of case it is. For chronic issues, the MRP should be contacted, while acute episodic cases can be referred to the NP. If a situation arises in the evening or on the weekend, then the appropriate on-call provider should be notified. In contrast, escalating a non-urgent situation involves writing in the MD-NP communication binder for the MRP to follow up during their next weekly rounds. So, to simplify the escalation process, I created this slide to pictorially demonstrate how best to communicate with the various healthcare providers. Specifically, for acute episodic cases that require urgent same-day assessment, the NP should be called. Again, these are those cases that emerge suddenly or there are new health concerns. If it is an urgent matter related to an ongoing chronic disease or issue, the MRP should be notified. Essentially, urgent situations are time-sensitive and require immediate intervention. For all non-urgent health concerns, staff should flag him in the MD-NP communication binder for assessment on the next weekly rounds. Again, these are cases where there is no immediate health or safety concern and same-day assessment and intervention is not required. So now, let's put these principles into practice by introducing a case study. I would like you to meet Mr. AJ. This is a 74-year-old male who was admitted on January 2nd, 2024 with a past medical history of bladder cancer and type 2 diabetes. Mr. AJ's chief concern is pain while voiding. So some additional context, Mr. AJ is a 74-year-old male with a history of bladder cancer and currently has a 14 French indwelling Foley catheter which was first inserted 5 days ago for urinary retention. Yesterday, Mr. AJ started complaining of pain while voiding into his catheter bag, and he's often seen and heard screaming throughout the day because of that pain. Recently, Mr. AJ has also been misplacing his personal belongings, and he can no longer seem to remember where he put them or the time of day it is. He has been taking Tylenol 1,000 milligrams by mouth as needed for pain, but reports that it is ineffective. There have been no previous investigations for these symptoms. So how do we communicate this information about Mr. AJ to the appropriate healthcare provider? We do this by using the S-bar, which is a structured communication tool that provides essential, concise information about a resident, usually during urgent situations. It facilitates information sharing amongst healthcare professionals. SBAR is an acronym that stands for Situation, Background, Assessment, and Recommendation or Request. When we talk about situation, the main point is what is the chief concern you are calling about. Background relates to what is the relevant history about this chief concern. Assessment refers to what is the main problem, what is going on about this chief concern. And then finally, recommendation and request is what you need to correct the problem, which is the reason why you're calling the healthcare provider. So if we delve a little bit deeper into S, situation, what is the chief concern? Well, here you would identify who you are, your role, and which RHA you are calling from. Next, you want to identify the resident you are calling about and explain the chief concern or reason for you calling the healthcare provider. So if we relate this back to our case study for Mr. AJ, the chief concern is pain on urination since yesterday. So if we take that information, what does that look like in terms of presenting the situation when you call the healthcare provider? Here is an example. Hello, my name is Rahul, and I am a nurse at Wellbrook Place, West 4C. I am calling regarding the resident Mr. AJ in room C418, who has a chief concern of pain on urination since yesterday. Next, we want to discuss the background. What is the relevant history related to that chief concern that we are calling the healthcare provider about? Here, you will summarize some of the pertinent medical history related to that chief concern and outline any recent symptoms that the resident is experiencing and their evolution. This includes changes from baseline or even mental status changes. You want to also describe any relevant interventions that you have implemented within your scope of practice and their effectiveness. You also want to list any relevant allergies, medications, lab tests, diagnostics, or imaging results that are all pertinent information that the healthcare provider should know. So what does the background look like for our case study, Mr. AJ? Well, for context, here are the pertinent details once again on this slide about Mr. AJ. So what is the relevant history related to Mr. AJ? Well, we know that he had previous urinary retention related to bladder cancer treatment, necessitating a 14 French indwelling Foley catheter, which was inserted 5 days ago. We know that Mr. AJ screams while voiding, and he's been experiencing increased confusion, which presents with misplacing his personal belongings, as well as disorientation to place and time. He has no known drug allergies or recent lab investigations, and he's been taking Tylenol for pain with little effect. So to summarize the background for this case study, here's an example of how we could present it to the healthcare provider. Mr. AJ is a 74-year-old male with a 14 French indwelling Foley catheter for urinary retention post-bladder cancer treatment from the hospital, which was inserted 5 days ago. The resident has been increasingly screaming in pain when voiding. He also has recently been misplacing his personal belongings and is often confused about their whereabouts. He does not have any known drug allergies and no recent lab investigations. He is taking acetaminophen as needed for pain with little effect. Next in the SBAR tool is A, which is assessment. What is the main problem? Here, you want to take a complete set of vital signs, a focused physical exam related to the chief concern, and a summary of your findings. Essentially, what do you think is going on? Currently, the staff in the units are very strong in the situation and in the background portion of the SBAR. The area that I want to challenge everybody to continue to develop is assessment, as we want to try to emphasize that critical thinking component. What do you think is going on related to the chief concern? So relating this back to our case study, here's some additional information. On physical exam, the vitals are a temperature of 38.2, pulse of 106, respiratory rate 22, and a blood pressure of 128/86 with an O2 saturation of 98% on room air. The resident rates their pain 8 out of 10 while voiding and 4 out of 10 at rest. In general, the resident is alert, disoriented to place and time, diaphoretic, and lethargic. On abdominal exam, you notice the resident is guarding with mild firmness in the lower quadrants and tenderness to palpation. From a genitourinary exam, you notice that the urine is yellow and cloudy in the catheter tube as well as the bag, but no bleeding is noted. Current treatment includes acetaminophen, which has been prescribed from 500 to 1,000 milligrams by mouth every 4 to 6 hours as needed for pain. And the main problem that you think may be going on given all this information, is a possible urinary tract infection. So now that we know all the relevant assessment information for our case study, what does this look like if we were to call the healthcare provider? This is one way we can say it. Current abnormal vitals include a temperature of 38.2, respiratory rate 22, and a pulse of 106. The remaining vitals are within normal limits. The resident rates their pain an 8 out of 10 while voiding and a 4 out of 10 at rest. Pertinent physical exam findings include intermittent disorientation to time and place, lower abdominal tenderness on palpation, and dysuria with cloudy urine in the catheter drainage bag. I am concerned that Mr. AJ may be developing a UTI. So the final letter in the SBAR acronym is recommendation or request. What is needed to correct the problem? Here you want to explain what you need from the provider related to the chief concern, and possibly even offer a suggestion related to that concern if appropriate. You also want to ask for clarification if you still have concerns, but remember, be specific and concise. So if we relate this back to our case study, here's an example of how we would present the recommendation or request portion of the SBAR. I'm calling to request an order to collect a urine sample to rule out infection and potentially start antibiotics. So these next two slides culminate this example of our case study and how we would present the appropriate information in a concise but specific way when we call the healthcare provider by using the SBAR tool. Ultimately, using the SBAR tool allows us to share information in a relatively concise and quick manner to make sure that any pertinent information that is required for the healthcare provider to make a treatment decision is expressed. On this slide, we are just summarizing the assessment and recommendation request portion of the SBAR tool that we previously discussed. This slide outlines the SBAR tool and provides a guideline that can help registered staff in the units to fill out to complete when they want to call a healthcare provider to ensure that all pertinent information is shared. This reference sheet is available in your RHA resource binder and is also available on the back of that placard of the NP stat on every nursing station table. So to summarize today's presentation, first, we discussed healthcare providers that are supporting the team. This includes the MD, which is the MRP. They have on-call as well as on-site weekly rounds, and they deal with the chronic disease management. That is, the slow developing and long-term related concerns. There's also an attending NP, which is on-site Monday to Friday, and they deal with the acute episodic concerns, which are the sudden, abrupt onset with new symptoms that are time-sensitive and require immediate assessment and intervention. NP Stat also has a similar mandate. They are also on-site, but their schedule varies, and there is also an evening and weekend on-call service available for acute episodic care. Second, we discussed urgent situations which require immediate intervention, and ultimately the staff should be calling either the MRP or the NP depending on the type of situation, whether it's acute or chronic. Third, we discussed non-urgent situations that do not require immediate intervention, and therefore staff should be flagging them in the MD-NP communication binder for assessment on the next MD weekly rounds. Fourth, we discussed that assessment determines the situation urgency. So for acute time-sensitive concerns, call the NP or the NP stat. For chronic related concerns or concerns related to admissions, contact the MRP. And finally, we discussed the SBAR tool for communicating clinical situations and escalating urgent health concerns in a structured, concise, and specific way to ensure that the pertinent health information is shared with the healthcare provider. And that concludes this presentation on communicating with healthcare providers. Thank you for attending Quality Care Rounds, and we hope to see you next time.